Thank you, everybody, and good evening. I'm Mike Bernstein. I'm a pulmonologist in Stamford, Connecticut, and I want to welcome everybody to tonight's Veracyte webinar on disrupting lung cancer continuum with novel genomic tests from diagnosis to treatment. I think we have a great presentation tonight, and I'm excited to get us going for the evening. Just to set the agenda for the evening, I will start the evening talking a little bit about the gaps in lung cancer diagnosis in the continuum of care. Then we'll move on to Dr. Bill Bulman, who's Veracyte's medical director for lung cancer, who will talk about Veracyte's vision for the portfolio for transforming lung cancer care. Bill will specifically address some of the gaps with two new additional tests that are in development that will help complement the commercial availability for the Percepta GSC, a test that some of you may already be familiar with. Lastly, we'll end with Dr. Chuckreddy, who will speak about the Percepta GSC and how he has incorporated it into his practice at the University of Utah. At the end, we'll have a few concluding remarks, and we'll wrap up with what I hope is a lively Q&A session to help bring people up to speed with the latest from Percepta. So just to introduce myself again, I'm Michael Bernstein. I am a pulmonologist and interventional pulmonologist in Stamford, Connecticut. I run the lung cancer screening program and the lung nodule program, and I've been working with Veracyte from a number of products for the last couple of years, and really excited for the things that they're bringing on the market. I'm going to speak specifically about the gaps in the lung cancer diagnosis and care continuum. I have the opportunity to really just sort of highlight some of the problems in lung cancer diagnosis, and it's always more fun to be a troublemaker than offer the solutions, which our speakers towards the second half of the presentation we'll get to address. So we all know when facing the diagnosis of lung cancer, there are many barriers for the diagnosis and treatment, barriers both for the patients and for us as providers and physicians trying to get them the best diagnoses. I'm going to highlight three of them in the beginning that I think are of clinical practice to all of them, and we'll set the stage for how Veracyte can actually help solve some of these problems later on. And the first one is going to be talking about lung nodules and how they're identified by screening or CT scan programs. Second, I'm going to talk a little bit about the difficulties in diagnoses and the problems we often face with that. And the last one, I'm going to talk about how treatment really is guiding us in terms of what we need to do nowadays for providing the best diagnosis for the patients. So specifically talking about lung cancer nodule identification and risk stratification. So determining the cancer risk for patient is something we do practically every day in the office, and we think about every time we see a CT scan that's applicable for these patients. Many of us use a series of calculators to figure these out. Ultimately, we know, thinking about lung nodules, that about 95% of nodules we will see on a CT scan are benign. However, if we send these patients to surgical biopsies or surgical resection, we know about 30% of the time we're still resecting nodules that ultimately have a benign diagnosis. And lastly, one of the other troubles we have from the beginning is physicians really do underestimate the prevalence or likelihood of disease. So we know 75% of the time physicians will opt for a less aggressive management for patients whom surgery was recommended by the guidelines. Looking more specifically at this, we all rely on a number of risk models, as I mentioned earlier. These models all have a number of limitations. So some people have risk models built into their EMRs. Many people use apps. Some people have guide cards in front of them. Three of the most common ones we think about are the Mayo, the Gould, and the Brock model. And all these prediction models were based on a population of which they were derived. And relying on that population model has a number of consequences ultimately moving forward. Many patients we're seeing now were part of lung cancer screening programs, and these were not really designed to use these models ultimately. Ultimately, physicians often just rely on their own assessment, which is often called a physician-assessed risk, or PAR. And we can see how this performs against some of the other major models. And while it may be a better model, it still somewhat has limitations. First of all, for the lower risk patients, we often underestimate, for the lower risk patients, we may often overestimate the likelihood of cancer. And particularly for higher risk patients, these will ultimately sometimes underestimate the prevalence. So relying on our classic model of just using a classic score or our own preference really still is a big gap for what we can do, and it's something that I think we can improve on for helping to get patients in the right direction. In lung cancer, there's still a number of barriers between the diagnosis and treatment, and moving on to the diagnosis is really a second place where we all often have problems. We all think of us, particularly those who do bronchoscopy, as always hitting the target and getting this, but we know in practice we miss the target sometimes, and we have to figure out how to put this in. And it's often relies to a big problem when we're looking at non-surgical biopsies. So this is a chart I think many of us have seen multiple times. This is the ACCP guidelines for non-surgical biopsies. I like to think of this in March as sort of the NCAA bracket turned on its side. And while most of us have sort of lost in our brackets over the last couple of weeks, ultimately, for us as pulmonologists, there are two common winners here, which are non-surgical biopsies. We can see these on the top on the right and on the bottom on the left. This guidelines look for patients and decide whether they're surgical candidates or not, and also depending upon our assessment for lung cancer. So for many non-surgical patients, we have to rely on a non-surgical biopsy for diagnosis prior to surgery. And for patients who are intermediate risk, we often want to find out the diagnosis prior to asking a thoracic surgeon to go straight forward with thoracic surgery. I think a third issue that often comes up is some tumors, while may be appropriate for direct surgery, often are in an anatomic location that surgeons often want to biopsy prior to surgery, and for them, bronchoscopy or another modality for preoperative diagnosis becomes important. So for pulmonologists, clearly many of us are thinking about bronchoscopy. Probably many of us were doing bronchoscopy earlier in the day. And we think of bronchoscopy in the big picture as bronchoscopy as we've added more and more technology. So simple bronchoscopy, we know from a generation ago, is probably accurate only about 40% of the time. Adding navigation to the bronchoscopy, either through advanced navigation techniques or even robotic bronchoscopy, will bring this number up. It's probably a little higher than 55%, but certainly heading in the right direction. And adding endobronchial ultrasound, whether adding a second site or real-time endobronchial ultrasound, may bring this up to an even higher rate. Thinking about transthoracic needle aspiration, this is a better yield for many biopsy sites, but it has a higher complication rate and often lacks in staging the patient and leaves some areas to be desired as well. But in the big picture, looking at bronchoscopy, we know that even in the best hands, bronchoscopy is missing a significant portion of the time. Somewhere, maybe in the best situation, 15 to 25% of the time, and the worst situation, over 50% of the time. So finding a tool to help us know when we didn't get a bronchoscopic diagnosis is something that really is important, and it's going to be addressed as the evening goes on. The last issue that I think is of the big issues for lung cancer diagnosis now is incorporating ideas of treatment right into the initial biopsy diagnosis. I like to think of myself as only being a few years out of fellowship. I'm not, unfortunately, at this point, but at that point, I remember thinking all we had to do was establish some biopsy diagnosis of cancer, pass the patients on to an oncologist, and then we can move forward. But in 2021, that's not really doing our patients any service. So knowing the NCCN guidelines for tumor profiling really has implications for how we approach diagnosis. So this is the NCCN most recent guidelines, and not going to walk everybody through in great detail, but highlighting the center section here and noting that for most patients getting any bronchoscopic biopsy, we are going to want to try to send the patients from direct molecular testing. So the top looks at patients who have adenocarcinoma, and here's that classic alphabet soup of new terms that we need to be familiar with to get the patients for the right chemotherapy: EGFR mutations, ALK, ROS, BRAF, NTRK, RET, and particularly now PDL testing is desired on most of the patients. For squamous cell carcinoma, in certain situations, they're going to be appropriate for the same testing as well, and certainly for PDL testing for most of these patients. Now, even a year or two ago, we didn't test for all these, but as more and more studies come out, we can see that up to 85% of patients will actually have potentially actionable mutation. As KRAS potentially has drug targets in the site, I think this is certainly going to rise as well. More importantly, in addition, we think of these as really only necessary in the past in patients who have metastatic disease, or stage 4 disease, or patients with advanced disease, stage 3B and 3C. But we can see that molecular testing is becoming more and more important for patients earlier on in their treatments. So there was a study this summer presented at ASCO that looked at Tagresso and found benefits for patients with stage 1B and 2. And it's not that far a leap to think that patients even with stage 1 lung cancer are ultimately going to need to know the molecular markers for these patients and trying to get the right amount of tissue for them. Now, there are a number of challenges we're presented with trying to get the right profile for these patients early on. Just to highlight 4 of the challenges, the first one I think we all face often is inadequate tissue. This is heard of at tumor board or wherever. And if you're doing bronchoscopic biopsies daily, you sort of understand the issue. You work with a rapid on-site cytology. I always like to say we sort of throw a fish over the net of the boat, throw a net over the side of a boat and pull a fish up on the deck, and we think we got enough tissue. And so therefore you do a couple more passes, but by the time you get to shore and ask the pathologist what you have, you realize your nets are just filled with rocks and seaweed. And so the adequate amount of tissue is really an issue. Second is there's a lot of logistical challenges in getting patients the right tumor markers in 2021. So if you ever follow your biopsies from the Bronx suite all the way through to the pathology lab, they ultimately need to be spun down, create a pellet, then paraffin embed, cut, stain, and depending upon how much tissue, many centers are faced with how and where to send these tissue markers out for. I know it's something I face every day on trying to work with as little tissue and getting as much information with the logistical challenges involved. There's also a number of emerging biomarkers, so I definitely felt that no matter what system we set up, somebody wants a new test the minute we finish the last one. And the last one is turnaround time, which is clearly something we all face. Patients want to go from the Bronx suite directly into their oncologist's office, and while we know it won't really make a difference, having actionable information for the oncologist quickly is clearly an issue, is important for them. Looking at this in the big picture, we know that because of the lack of tissue or the challenges going along, 13% of patients will ultimately need a rebiopsy, often right after their initial consultation with a medical oncologist. Moreover, data from only a couple of years ago shows that almost 50% of patients, or a little more than 50% of patients, don't even have the 2 most common tests that we look to be sent, EGFR and ALK, prior to receiving any form of chemotherapy. And on top of that, only 21% of patients have all these results back by the time of their first medical oncology appointment. Now, this is a little bit of a tug here that the oncologists don't really want to see the patients until they get the information, and the patients want to be seen as soon as possible. So the best way to marry that together is to get information to everybody as soon as possible. So I wanted to just start the evening out by just highlighting a number of the barriers that are out there, from lung nodule identification to helping with diagnosis in terms of indeterminate or non-diagnostic biopsies, and really incorporating the treatment or molecular markers for the patients as the diagnosis of cancer progresses. Ultimately, this will help for lung nodules bring objectivity to the lung nodule assessment. For lung diagnosis, we can improve the outcomes from our biopsies, and thinking about the treatment or the best way to mark the tissues, we'll get earlier treatment times for the patient and better treatment times there. So it's kind of fun to highlight some of these problems in the beginning, and hopefully my colleagues tonight are going to be able to elucidate some of the solutions as we go on. So I'm going to turn over next to Dr. Bill Bulman, who's the medical director of Veracyte, and formerly just down the road from me at Columbia University. And I think he has some very interesting things to talk about in terms of what's going on in the future.
Thank you very much, Mike. I am going to be talking about Veracyte's vision and their lung cancer portfolio, the way Veracyte is using genomics-based tools to try and overcome some of the barriers that you addressed. I am, as I said, the medical director for lung cancer, but I'm very, very new to that role. I joined Veracyte just a few months ago, having spent 27 years at Columbia University Medical Center in New York. For the last 15 years, I've been in pulmonary and critical care medicine, and I've been the director of bronchoscopy for the last 12. I also ran the Columbia's high-risk lung nodule assessment center. So lung nodules, the management of lung nodules is near and dear to my heart. Just a few minutes about Veracyte. Veracyte is a genomic diagnostics company that was founded in San Francisco, or South San Francisco, 15 years ago with a single genomics-based classifier for thyroid nodules. And in the past 15 years, they have grown enormously into a global company with 400 employees They have presence either commercially or with products in development in 7 of the 10 most common cancers in the United States. And they have Medicare-covered genomic tests currently available for thyroid cancer, lung nodules, and lung cancer, breast cancer, and prostate cancer. Plus, they have a pulmonary portfolio that also includes a genomic classifier that many of you may be familiar with, the Envisia Genomic Classifier for interstitial lung disease, specifically for identifying or categorizing people as UIP. So most of Veracyte's tools harness the enormous amount of data that is available in RNA whole transcriptome sequencing. And Veracyte combines this enormous amount of data with advanced machine learning. Now, many of you in the audience may know a lot more about advanced machine learning than I do, but for those of you who don't, advanced machine learning is using enormous quantities of data and passing it through a computer algorithm where the computer analyzes for patterns in that data. And that analysis, that result, is then used to enhance the algorithm. And the data is passed through iteratively over and over and over again, training the algorithm. When this technology is applied to patients with cancer, the result can be a genomics-based classifier that can inform when the computer and the algorithm get a new piece of data, a new set of RNA sequencing. You place a new patient's data and run it through the algorithm, and you could potentially classify an individual with a cancer as having a good prognosis or a poor prognosis. You could classify a patient with a lung nodule as having a likely to be malignant lung nodule or a likely to be benign lung nodule. In the clinical or in the studies in the development of these classifiers, Veracyte has tested over 20,000 patient samples and a total of over 4 billion genomic transcripts in the development of these classifiers. And then in clinical use, there's been a full 200,000 patient samples that have been analyzed for a total of over 40 billion genomic transcripts. And all of this data has gone to form huge clinical biorepositories that enhance the ability of these classifiers. So I'm going to talk about all 3 of these that appear in the slide that Veracyte has as potential tools for overcoming these barriers. The first and the third are tools that are still in clinical development, but tools that Veracyte hopes will be available commercially at the end of this year. And then Dr. Reddy is going to talk in more detail about the Percepta Genomic Classifier, which is commercially available now. So first, the Percepta Nasal Swab Classifier. This is the first nasal classifier, the first classifier for lung nodules that does an initial risk assessment based on genomic changes in the nasal epithelium. It actually informs on the nature of a lung nodule by sampling in the nose. This is a novel concept, but it is one that is based on many, many years of solid science. Back in 2007, Aboutvirasite and colleagues presented the paper that demonstrated that gene expression in normal airway epithelial cells from smokers and former smokers could serve as a lung cancer biomarker. This essentially utilized the already then well-established principle of field of injury. Field of injury basically says that the DNA damage from smoking that led to carcinogenesis in a lung nodule, that led to the development of cancer, could be detected in the rest of the airway as well. Epithelial cells away from the lesion could give us genomic information that could inform about the lesion. This led to the development of the bronchial classifier that eventually evolved into the Percepta GSC that you'll hear about. And that was published by Gerard Silvestri and colleagues in the New England Journal of Medicine in 2015. This led to further work that showed that the same genomic changes, the same field of injury changes, could be seen in the cells collected from the nasal epithelium, all part of the same airway exposed to the same cigarette smoke. The proof of concept that a nasal classifier could be used to characterize lung nodules was presented by Carla Lamb and colleagues at CHEST in 2019. Veracyte has gone on building on this data to further refine the classifier, the nasal classifier, and to perform clinical validation on the classifier, and hopes to share the clinical performance characteristics of this test later this year. And as I've mentioned, launch this as a commercially available product. This is an incredibly simple test, a nasal swab to be done in the office. But that really hides the enormous complexity of the classifier that underlies it. Lung cancer is a disease with enormous heterogeneity, so the classifier has to accommodate that heterogeneity. And in order to do so, Veracyte enriched the original cohorts with more patients, added new cohorts to bring diversity to the types of patients that were being used to train the classifier. And then they built and refined genomic indexes that serve as a foundation to address the complexity of lung cancers. They built indexes to address smoking status in patients, different patients with different cancer stages, different types of cancer, different nodule sizes. And this has been termed, the result has been termed an algorithm of algorithms. But all of this and some clinical features go into determining the nasal classifier and help establish it as an accurate determinant of risk in patients with nodules. Patients who are eligible for the nasal classifier are patients who have a smoking history, who have screen-detected nodules or incidental lung nodules were found on CT done for other reasons. And what we have learned in the preliminary data is that nasal swab classifier, the numbers here are data from the proof of concept from Dr. Lamb's presentation at CHEST, but fundamentally the nasal swab classifier is allows a physician to more accurately characterize a lung nodule as either high risk or low risk. This is initial lung nodule risk assessment that is personalized to the patient. It's based exclusively on the genomics of that individual patient and their individual risk. It's really personalized medicine applied to lung nodule risk assessment. Accurately characterizing patients as either high risk or low risk is absolutely critical in determining who gets CT surveillance and who gets more aggressive evaluation and possibly being directly sent to a surgeon for early cure, for timely cure. Dr. Lamb's data suggested that the application of the nasal classifier could minimize or reduce the number of patients that are in this intermediate category, putting more patients appropriately into high risk and low risk. The classifier has two different cutoffs for high risk and low risk, and that allows the classifier to have good performance in both categories, have good specificity for high risk nodules, and therefore a good positive predictive value, and high sensitivity for low risk nodules, for benign nodules, and therefore a high negative predictive value. Having a high negative predictive value allows a physician to more reliably ensure that patients are avoiding unnecessary procedures for benign nodules. And they are similarly allowing physicians to direct more patients to aggressive therapy when that is appropriate. So I like to think of this from the patient's perspective. So think about a patient who has smoked for 50 years, a pack a day, and quit 10 years ago, and they're told by their physician that they are at high risk for lung cancer. And they are told that they should get screening for lung cancer on that basis, and the basis of the fact that they're high risk. And that individual in their first screen gets a 7-millimeter nodule in the upper lobe detected. That person is going to be categorized by the radiologist as LungRad3, likely benign. And statistically, that's true. Most small lung nodules are going to turn out to be false positives on screening. But you've just told this patient that they're high risk for lung cancer, and now you've told them based on a LungRad3 categorization, they have to wait 6 months to find out that they do or don't have a high-risk lesion. They have to wait 6 months to find out if this lesion has not grown or has gone away, or they have to wait 6 months to find out that it's grown, and therefore action needs to be taken. And I ask, why does a person with cancer, if they're in that small percentage of people with a 7-millimeter nodule on screen that is cancer, why does that person have to wait 6 months for their diagnosis and their definitive treatment, their cure? And why does a person with a 7-millimeter benign nodule need to wait 6 months? It's filled with anxiety that they are, in fact, harboring a cancer, even if they know statistically that's unlikely. So we now have new tools that can help inform, after the identification of a nodule, exactly where this patient's risk lies And we can give the patient some reassurance with this nasal classifier that they are in fact safe to wait without anxiety for their 6-month CT. Or we may need, in the clinical context and with the evidence from this nasal classifier, to accelerate those patients that we think might actually have the 7-millimeter adenocarcinoma. So I'm only going to very briefly talk about the second tool. This is, as I said, now commercially available. This is something that I used in my bronchoscopic practice. This is the Percepta Genomic Sequencing Classifier, the evolution from the original 2015 New England Journal study and the original bronchial classifier. It is the same test, however. It's a bronchial brushing of the right main stem bronchus in a patient who has a lung nodule, and it is run when the bronchoscopy is non-diagnostic. I looked at this as insurance against the non-diagnostic biopsy. It drove me crazy to have to tell a patient, we tried to get an answer and it was non-diagnostic and you're going to need another procedure. I absolutely liked to have more data so I could go to that patient and say, look, we were unsuccessful at getting, we talked about the possibility of a non-diagnostic result, and that was the case. But we now have genomic data that can either stratify our level of concern up or hopefully stratify our level of concern down and inform where we go next with this patient. If it's to more aggressive interventions, if it's to another biopsy, fine. If it's more watchful waiting, because we have evidence that this is in fact a low-risk nodule based on the genomics from this classifier, that's even better. So finally, and again, you're going to hear much more about this from Dr. Reddy, and hear how he uses the bronchial GSC, the Percepta GSC, in his practice. So I'd just like to say, many people have asked me, why did I leave academic medicine and come to Veracyte? It is these two tools in development, the nasal classifier and the Percepta Genomic Atlas, that I learned about in meeting with the people at Veracyte, and that got me incredibly excited about what is coming in the very near future for patients with lung nodules and lung cancer. This is the reason why I am a part of the Veracyte Medical Affairs team. So the Genomic Atlas, Percepta Genomic Atlas, is not a classifier. The Percepta Genomic Atlas is comprehensive genomic profiling, what's recommended for patients with advanced disease by the NCCN, that is geared specifically to the lung cancer patient. It is an NGS, a next generation sequencing profile developed exclusively for lung cancer, and even more specifically, developed exclusively with bronchoscopy and the sampling that's required for making a diagnosis and a staging for a patient with lung cancer bronchoscopically. This uses targeted DNA sequencing and whole transcriptome RNA sequencing to identify all of the NCCN core variants, to do broader sequencing to identify single nucleotide variants, copy number variants, insertions, deletions, and then RNA whole transcriptome sequencing to identify expanded fusions. But most importantly, I think it is done with tissue taken at the time of the initial bronchoscopy. Some of the initial bronchoscopy tissue is put aside for RNA sequencing, and it requires a very small amount of tissue. This is RNA sequencing and DNA sequencing that's being done at a specimen collected at the time of the bronchoscopy. So in essence, it's the next generation sequencing being done in parallel with histopathology or cytopathology, not done in sequence. So speaking of things that used to drive me crazy, the idea of insufficient for diagnosis as a bronchoscopist just really just aided my sense of self-worth. I had to tell a patient, yes, my procedure was successful, but we didn't obtain all of the information that was needed for all of the testing that's needed for you to have an informed conversation with your thoracic oncologist. And we would have to either plan for another biopsy, which could potentially delay their care, or initiate care without that information. That could happen because of tissue depletion. We had rapid on-site cytology at our institution, and that would waste some tissue. Yes, you would get confirmation that you were in a lymph node and that there were cancer cells there, but that tissue, having once been stained, couldn't be used for anything else It couldn't be used for next-generation sequencing. And then between staining and immunohistochemistry and at our institution, some targeted mutation analyses with PCR, it was not infrequent that there was insufficient tissue for next-generation sequencing, or even worse, it would be sent thinking that there was sufficient tissue, and we would get a report back from outside NGS saying that there was insufficient tissue, all leading to delays in that information being given to patients and to their oncologists. So by upfronting the acquisition of this tissue for next-generation sequencing, we're improving patient care. The performance of this test, again, developed specifically for patients with lung cancer, has been tested by Veracyte against reference assays and found to be highly concordant. More importantly, it's been tested where it needs to be tested, which is in bronchoscopic specimens. These are individual specimens from some EBIS tDNAs, a few bronchial brushings. What we find is a very high level of concordance, greater than 95% versus a reference assay. So essentially what we're doing here is hopefully eliminating some of these barriers, upfronting this information, prioritizing this information for patients for whom it may be a priority, may determine the appropriate treatment, and hopefully presenting a faster way to personalize treatment. So Veracyte, I believe, is bringing genomic tools to play to overcome some of these barriers in improving patient care. The nasal swab brings personalized genomic-based risk assessment, accurate risk assessment to appropriately guide a patient's next step when a nodule has been identified in a former smoker or smoker. The Percepta GSC, I believe, insurance for the non-diagnostic biopsy, the inconclusive biopsy. And then the Genomic Atlas, a comprehensive lung cancer-specific next-generation sequencing platform designed to inform treatment decisions using tissue acquired at the time of diagnosis. All of these developed with intense scientific rigor. Veracyte knows that that's required in order for patients, for physicians, to have confidence in the tests and their results. So I just would like to leave you with Mike Bernstein said that he believes that lung cancer treatment paradigms are going to shift as we move forward toward early stages. I would just like to share the one patient who I biopsied who had clearly a stage 1 cancer, and we did expanded profiling in this individual for very specific reasons. She was 100 years old when we biopsied her, and we followed a nodule for a period of a year and watched it grow, and she didn't go anywhere, so we finally decided to biopsy it. And she was not someone who was going to undergo surgery. She was not somebody who was going to tolerate radiation therapy, but she had an EGFR mutation, and we were able to, with that information, treat her stage 1 tumor. And I'm very happy to report that she died at 102, not of lung cancer, and tolerated treatment very well. So I do believe that the treatment paradigms are going to shift towards more and more attention to these mutational abnormalities in patients with earlier stage lesions. So with that, I'm going to give this over to Chuckreddy, who's going to talk about Percepta GSC in his clinical practice.
Thank you, Dr. Bulman. My name is Chuckreddy. I'm an interventional pulmonologist at the Huntsman Cancer Hospital at the University of Utah. And I also run the lung cancer screening program at the University of Utah. And I was going to talk about my practice and how we incorporated the GSC testing into our routine bronchoscopies. Both Dr. Bulman and Dr. Bernstein highlighted the importance of bronchoscopy and the drawbacks with bronchoscopy with the inconclusive testing. Typically, when you see a patient with a nodule on a CT scan, your options are either if you're really certain that this is benign, in which case you will opt for a more conservative approach, which is surveillance. However, if the likelihood of this nodule being malignancy is high, your options are either a bronchoscopy for biopsy or a transthoracic needle aspiration for biopsy. Depending on the location of the lesion, if you do choose bronchoscopy, you need to understand that more than 50% of the times it may be inconclusive, and you need to be prepared for how to handle these inconclusive biopsy results. And that's where we think Percepta fits in perfectly in terms of trying to kind of give us a roadmap for how we should proceed once we have inconclusive biopsy. Dr. Bulman actually went over the concept of field of injury, and I'm going to actually show you a brief animation that kind of shows you the same thing again, explains it.
Current or former smokers with lung cancer, gene expression changes exist throughout the airway. The Percepta test detects these genomic changes to determine the likelihood that a nodule is cancerous without the need to sample the nodule directly. The test relies on cells taken from the easy-to-reach main airway, which are collected at the start of a bronchoscopy. When bronchoscopy results are inconclusive, Veracyte runs a Percepta classifier in a CLIA-certified lab. The test uses RNA sequencing to stratify the risk of primary lung cancer for intermediate pre-test risk patients to either low risk so they can potentially avoid unnecessary invasive biopsies or to high risk to inform next intervention steps.
So the way the workflow typically goes with incorporating Percepta is if you have a patient that has a low pretest likelihood of the lesion being malignant, most likely you won't be doing a bronchoscopy, but if you do, and if the biopsy was inconclusive, however, you ran the GSE test, and if it comes back as a very low risk, then the negative predictive value of the test is greater than 99%. So you can be fairly certain that this is a benign lesion. However, majority of where B2 Percepta test and where it's actually helpful is if my pretest probability is in the intermediate level and we opted to do a bronchoscopy. However, if the bronchoscopy results were negative and the Percepta result gives us a risk of risk in the low category, then again about 91% negative predictive value that this is benign. And these patients you can probably confidently categorize them as low risk and just do routine surveillance with CT scans and avoid invasive procedures. However, if your Percepta risk comes back as high, then what we need to understand here is there's a 65% positive predictive value that this could be malignancy, in which case you should be planning on either repeating a bronchoscopy or performing a transthoracic needle aspiration. And if that's not an option, then talking about either SBRT or a surgical resection if the patient can tolerate surgery. And typically, if our pretest possibility is high and if the biopsy is inconclusive, however, Percepta comes back as very high, you can be assured that there's a high risk of this being malignant, so you should be planning for either a transthoracic needle aspiration or a surgical lung reduction. A surgical lung resection of the lesion. I'm going to go over one of the cases that I have had recently. This was a patient, a 68-year-old male, has a 35-pack-year history of tobacco use, which he quit about 2 years ago. He qualifies for lung cancer screening, and he had his annual low-dose chest CT, which actually showed a 15-millimeter left upper lobe spiculated nodule. This was his first low-dose chest CT. Given the location of the lesion, it's fairly medial, and the lack of an airway actually going to the lesion, we realized that the biopsy may be difficult, so we opted to get a PET CT because the lesion meets the size criteria for a PET. The PET CT showed a max SUV uptake of about 3.8, which again is sort of borderline. And when we used all this data on a Mayo risk predictor, it came back in the intermediate range at about 23.8% probability of this being cancer. So we decided to perform a navigational bronchoscopy on this patient, and at the time of doing the navigational bronchoscopy, we also ran the GSE test. We obtained a brushing from either the trachea or the mainstem bronchi before actually proceeding with the navigation itself. And as we sort of expected based on our on-site evaluation, the biopsy was inconclusive. It just showed a reactive bronchial epithelial cells. So typically what we do is we collect the GSC results, we send them out. However, we don't run them until we get the biopsy results. If the biopsy comes back and if I have an answer for this being malignancy, then we don't run the GSC test. However, if the biopsy is inconclusive, then we request the GSC test to be run. And when we ran the test, the risk actually was downclassified to low. With this information, it was a shared decision-making process with the patient where we explained that the bronchoscopy results were non-diagnostic. However, the GSC downclassifies the patient to low risk, so we can probably monitor this without actually jumping to a surgical resection or a transthoracic needle aspiration, which in this patient would have been a fairly high-risk procedure given the location of the lesion. So with that, we opted to just follow this with a CT surveillance. We had him come back 6 months later, and on a follow-up CT, the nodule had actually decreased in size to about 12 millimeters. With this, we were fairly confident that this is probably a benign lesion, and the Percepta test helped us avoid a TTNA or a surgical resection in this patient who most likely has a benign lesion. And he's now back to annual low-dose chest CT, and we'll be keeping a close eye on this lesion. So the way we have integrated the GSC test into our protocol is anytime we have a patient with intermediate to high likelihood of a CT-found lesion to be malignant, and if we are planning on doing a bronchoscopy, we always let our schedulers add on our schedule that this is a case for Percepta as well. So the technician usually sets us up even before we start the procedure or navigating to the lesion. We first get a brushing from either the trachea or the mainstem bronchus. And then once we finish the procedure, we wait for the results. And if we have a positive result from the biopsy, then we just ignore the Percepta, we don't run it. However, if the result comes back inconclusive, then we request the Percepta test to be run. If there's a down classification from intermediate to low, then we usually have them wait and perform repeat surveillance CT scans. On surveillance CT scans, the lesion continues to grow, then we plan on a more invasive test. But otherwise, we don't directly go to invasive tests, especially when the GSC test comes back with a low probability. If it's intermediate to intermediate, then that's something that we discuss with the tumor board and with the patient for shared decision making. If the team feels that the likelihood of this being cancer is high, then we go for a transthoracic needle aspiration. But if the team feels that this is something that can be watched, then we just proceed with a more conservative approach, which is CT surveillance in 3 to 6 months, depending on what the whole team feels is relevant. And this is actually our own data. We've had about, this is about 48% of the patients where we had no, where the biopsy was inconclusive. The GSC test has actually helped us reclassify the risk. In about 50% or 55% of those patients, it was actually a down classification from intermediate to low. So those are the patients where we were able to avoid doing a more invasive test and take the conservative approach. And with this, I will pass this back to Dr. Bernstein to discuss his experience with the GSC test and take questions after that.
Thanks so much, Chuck. I think I'm going to make a few comments about, we've been using the GSC classifier in practice in Stamford here for about 5 years in a very similar model. I think probably the most important thing I've learned over the years is just like the technical aspects of bronchoscopy get better the more times you use any equipment or any procedure. I think this test actually gets easier to use the more times you incorporate it into your practice and feel more comfortable, particularly for helping low-risk patients be down-classified more. And that's probably the point where we've had the best success. A number of patients who, when we have a non-diagnostic bronchoscopy, similar to the case you have, probably could find some images very similarly with that we've waited. And in all the cases so far, we've just continued to wait as well. Up classifying from high to very high is something I think is only more recent with the new way the test is working, and incorporating that into our practice as well. I think, one, it gives more confidence to go on for another procedure if need be. And as I mentioned earlier, we have a couple cases where we have lesions that are difficult for a surgeon to do anything but a lobectomy prior. And in these patients, knowing that you have a biopsy before a full lobectomy is often nice for a surgeon. So if I can think of 2 cases on hand, that we, unfortunately, I didn't hit the target to be able to say confidently that the patient had cancer, but up-classifying them from high to very high gave confidence to go right ahead with surgical resection, which I think made for a better surgical case for the patients and hopefully better outcomes. So I think people are using it more and more in their practice. I know we have for a couple of years, and it's easier for me to use. I think it's easier for the people who also work with us on the lung cancer team, whether it be other pulmonologists who don't do quite as many biopsies but refer patients in, or thoracic surgeons to understand the utility of the test has really helped. So I'm going to end with a few closing remarks, and then we're going to be able to take some questions. So if you have questions, feel free to put it into the Q&A list on the side here, and I'll be able to feed it over to Dr. Reddy or Dr. Bulman, or try it myself. But just some remarks, not really to close the night out, but to close some of the talks out before we move into the Q&A section. Clearly, the Percepta lung cancer portfolio for non-invasive genomic testing will really help improve diagnosis and treatment along the continuum of care. I've been fortunate to be involved in a couple of the Percepta trials early on, and some of the new trials that Veracyte in general is doing. And just this week, I've done nasal brushings and done Atlas testing together, as well as sending the conventional GSC test as well. So the nasal brushing, I think, is really going to bring a new level of objectivity, more than just the classifiers that we use, whether it's the Mayo model or our own physician-assessed risk. The Percepta GSC test, really, I think most of us have already seen in practice how it can help our patients and help us really figure out what to do with these intermediate risk patients and in non-diagnostic biopsies. I know myself, I'm really excited about the other two, but I think in terms of getting the genomic profiling for lung cancer in terms of the molecular markers is really an exciting thing that Veracyte's really on the forefront through. I did one of these cases today. Although we don't know the answers, I can say from a technical standpoint, it's very easy to put into the tubes and get ready, and you can see how these will turn around in faster time for the patient. So with that, I'm going to look on the side here and see if we have some questions and go from there. So.
Well, just to give you a second to scroll some of the questions and get an idea as to how you wanted to go forward, I just wanted to add one thing about the Percepta GSC. We at Columbia use this occasionally in patients who had peripheral nodules that we thought were very high risk and were going to be impossible to biopsy in any safe way. They weren't accessible bronchoscopically, and the patients, for reasons of emphysema or age or comorbidities, were very high risk for a transthoracic needle biopsy. And in those cases, radiation oncology is very reluctant to treat without a diagnosis. But if you go to them with a Percepta finding that is high risk or even intermediate risk, you can push them potentially to treat those patients without a diagnosis, to get ablative therapy in an attempt to cure what is suspected to be a cancer with just as much available data as can be safely obtained.
I'd agree, Bill. I can think of cases that we've done locally. So from there, I'm sure Dr. Reddy has as well. I'm going to start with the first question here, which was directed to Dr. Reddy about how you have the choice to collect a sample and either to run it or not run it. This is sort of a technical question about the process for Veracyte. So it's a good question, and I think a lot of people who haven't sent the test, understanding how easy it is to use really is helpful.
Yes. So what we do is we collect them, we put them in the tubes for the recommendations in the test kit, and we actually ship it out. However, we leave, the way we work with the Veracyte is we tell them that they are to run the test when we call them to go ahead and run it. They actually, Veracyte actually holds it for us, and they don't run it until we actually call them 2 or 3 days later and tell them that we'd like it to run and send the results to us. And so we don't keep it with us because we don't like to store them in the endoscopy lab. We ship it out, so it actually sits with Veracyte until we call them later to tell them to run the test.
Yeah, I can comment on my own side that this all works really easily if it runs through your pathology department. And our cytotechnicians take it all. I don't know if that's how you guys do it out in Utah, but they take the whole sample with them down to the lab and process it, ship it out. It sort of leaves the bronchoscopy suite just the way every other sample does.
Yeah, we usually just ship it right from the endoscopy lab, the Percepta samples.
We have another question here. I think this one is probably best for Dr. Bulman. It's asking, what are your thoughts on the future for lung cancer diagnostics and the role for pulmonologists in terms of lung cancer diagnostics?
Well, I mean, the first comment I'll make is that the pulmonologist doesn't exist in isolation in this process. They really worked hand in hand with the thoracic oncologists, the thoracic surgeons, and the radiation oncologists in determining what is the best patient care and how to best get a patient from the point of a nodule identification to hopefully curative treatment for their cancer. And that collaboration exists hopefully at all the centers where you all practice. That collaboration is going to be increasingly important as the types of data that we need to acquire for patients gets more and more complicated. And the pulmonologist has to ensure the thoracic oncologist, or the pulmonologist has to ensure the thoracic oncologist that they're reliably going to get the data that they need. So that has to be a process of communication. The evolution in the next bunch of years is, I think, going to be driven by the advances in targeted therapies and immunotherapy and lung cancer screening. And maybe it's the latter that's going to change the paradigm even more for pulmonologists with respect to lung cancer. We are going to see, hopefully, as lung cancer screening it becomes adopted more and more widely. I think we all know we currently do a bad job of screening patients who are eligible for lung cancer screening. But the hope is that 2 years, 5 years from now, patients who are eligible are going to be screened. The millions of patients who are eligible are going to be screened. So what we're going to be finding is more and more, we're going to find lots of false positives that need to be addressed, and those can be addressed with the Nasal Classifier and accurate risk assessment. But we're also going to be finding more early-stage cancers and curing more early-stage cancers. And the pulmonologist who does cancer nodule biopsies and cancer biopsies is going to be right in the heart of that evolutionary change. So that's kind of a long-winded answer, but we have to be involved in knowing what the appropriate treatments for cancer are, because it's our job to get that information reliably for patients. And we're going to be intimately involved in the management of earlier-stage patients, hopefully patients on a path to cure.
Bill, the next question on here I think is a more technical one, so better addressed to you as well. It's asking how the test, and I think this may be related to the Atlas, how it performs with patients with unknown pulmonary malignancies.
So the test is generating lung cancer specific, the targeted mutations that are recommended by the NCCN for lung cancer. It is, however, obtaining RNA whole transcriptome sequencing, and the other genetic information is available in there for other mutations. I don't currently know exactly how that might be accessible after the fact. It may be that a patient who is suspected to have another type of cancer should get standard next generation sequencing and not a lung cancer specific platform. The test really is still in development, so I honestly don't know the full answer to your question.
I'm going to ask a question here over to Dr. Reddy, and I know it's something that I faced early on, which is I think many people, pulmonologists now work with interventional or advanced diagnostic groups that have referrals from other pulmonologists within their own group. In terms of using the GSC classifier, how have the other folks who are referring to you for pulmonary nodules either understood how the test is used, or are they asking for you to run this test on their patients right along at the time of referral?
No, they're. I mean, whether or not they ask us, Mike, we're already doing it. It's a part of our, the way we have kind of created the workflow. But definitely, you're right. A lot of pulmonologists are, it's interesting because there are some cases where pulmonologists have attempted a biopsy and they don't have navigation system, or they were unable to get a diagnosis. However, they've actually run the Percepta already, and it's, especially the ones we get are when they're from intermediate to intermediate. and they send them to us for interventional pulmonologists to take a look and see if you can actually do a navigation bronchoscopy on those. Fortunately, they're not a lot, but when we do get them, it raises an interesting question, because if, say, I were to do it, and if I were unsuccessful as well in getting a biopsy, then what do we do? And you're right. I mean, it's a very a complex process of trying to determine how to deal with these inconclusive biopsies, especially if it's inconclusive, say, the second time, or you did a transthoracic needle aspiration, and if that's inconclusive as well, then what do you do? Especially if your GSE is saying the risk is high. But you're right. I mean, we do see a lot of pulmonologists now are doing this procedure themselves at the time of regular moderate sedation bronchoscopy, or a lot of times you see folks trying to do a BAL for a pulmonary nodule, and the BAL yield is really low. However, they run a Percepta at the same time, and so that kind of gives them more information. It's a changing, I think, environment, and we'll have to wait and see. My guess is as more and more pulmonologists are going to be, doing bronchoscopies for evaluation of these nodules and running Percepta, I think it's going to be interesting to see how we're going to interpret those results in terms of what the next steps would be for inconclusive biopsies.
We got time for about one or two more questions. I think earlier on we asked a question about the role of the changing field for pulmonologists. I'll ask this question over to Dr. Bulman again. In terms of the nasal risk, do you see this being something that's going to be used at high-risk lung cancer clinics, or we know that if every pulmonologist in the country had to see every pulmonary nodule, we never get through our day, and certainly most of us in the last year have been taking care of COVID half the time, so certainly not enough of us around. Do you think that the nasal risk test will be used in the primary care office or used more specifically in the pulmonary offices?
I think you alluded to use in screening centers. I think there is an enormous opportunity to protocolize the use of the Nasal Classifier in lung cancer screening settings. ACR certified lung cancer screening programs have care navigators and nurse navigators. The idea that a positive finding is followed up immediately with a nasal swab could be incredibly impactful. And then that data is available when the patient is seen by a pulmonologist if needed, if the finding is actionable, is intermediate or high risk. And it may be that patient doesn't need to see a pulmonologist because we now have additional data that particular patient is low risk, and that could be a patient managed exclusively by the care coordinator for the lung cancer screening program. You're absolutely right. There are going to be many more nodules than pulmonologists to see them, and it's really essential in my mind that the higher risk patients be prioritized with respect to their access to pulmonologists. But linking nasal risk assessment, initial risk assessment, to the screen finding itself is something that could really sort of change the lung cancer screening paradigm.
So we've sort of hit the end of the hour here, and I think many people worked a full day and joined us at the end here. But I hope, I know for myself, I've learned a lot every time I even hear these presentations about all that's exciting and new, adding genomic classifiers for lung cancer. And certainly the way we're doing business in 2021 is probably not the way we're going to be doing business over the next 4 or 5 years. So with that, I think we're going to end the evening. And again, thank ATS for helping to support this, and have a great night.